Good morning, everyone. My topic is bacteriological study of catheter in a tertiary care hospital, a prospective study from Government Medical College and urinary tract infection is one of the four most common infections in people, accounting for quite 150 million instances worldwide. In addition to being the customized bacterial infection, conjointly account for 36% of all healthcare associated infections. Of those infections, 80% of them are predicted to be associated with indwelling urinary catheter. The indwelling catheterization has emerged as a dormant cause for morbidity among patients admitted within the hospital and has gained a primary significance in patient outcome. The aim and objective of the study is to identify microbial pathogens associated with catheter-associated urinary tract infection in catheterized patients from intensive care units and to determine the susceptibility patterns of these isolates to antimicrobial agents and associated risk factors. The materials and methods are, this was the cross-functional study of catheter-associated urinary tract infection conducted in medical wards, ICUs, COVID wards, surgical wards of a tertiary care teaching hospital over a period of 8 months, that is from September 2020 to May 2021. The study was approved by the Research and Ethics Committee. Informed consent was obtained from each patient's next of kin. The urine sample was processed by standard microbiological procedures. Organisms were isolated and antibiotic susceptibility was performed. The inclusion criteria are all the patients aged more than 18 years old with indwelling catheter. And exclusion criteria are all patients with clinical suggestive of pre-existing UTI, catheter put outside hospital or other sources for fever or admission. Evidence with alternative diagnosis other than CAR-T were excluded from the study. The study outcomes are like this. The gram-negative organisms like E. coli, Klebsiella pneumoniae, and Pseudomonas aeruginosa were the most commonly isolated than gram-positive cocci with high mortality rates. Female gender, increasing age, and longer duration of catheter density were risk factors for CAR-T in the present study. My data collection strategy is as follows. All patients included in the study were monitored at frequent intervals for the development of CAR-T using clinical and microbiological criteria until either discharge or removal of catheter. Criteria for diagnosis of catheter included the diagnosis of CAR-T was based on clinical and microbiological criteria mainly. Signs and symptoms compatible with CAR-T include new onset or worsening of fever, rigors, altered mental status, malaise, or lethargy with no other identified cause, flank pain, postovertebral angle tenderness, acute hematuria, pelvic discomfort, and in those whose catheter have been removed, dysuria, urgent or frequent urination, or suprapubic pain or tenderness. CAR-T in patients with indwelling urethral catheter is defined by the presence of symptoms or signs compatible with UTI with no other identified source of infection. The diagnosis was confirmed by performing a quantitative culture of the urine sample and observing more than 10^4 colony-forming units per ml and culture positives. Based on these criteria, 137 out of 300 were enrolled with diagnosis of CAR-T. Organisms isolated with quantitative counts less than 10^5 colony-forming units per ml from the replacement catheter tend not to persist. Statistical analysis is like data entry and analysis were performed using SPSS for Windows version, SPSS 14.0 software. Means and standard deviations were calculated for numerical variables. The chi-square test was calculated and all values for p less than 0.05 were considered statistically significant. Odds ratio and relative risk was calculated for univariate analysis. Discussion includes definition of CAR-T. The term catheter-associated urinary tract infection is used to refer to individuals with symptomatic infection with catheter in situ. The diagnosis of symptomatic CORT is often a diagnosis of exclusion. Fever without localizing findings is the usual presentation of CORT. Localizing signs or symptoms such as catheter obstruction, acute hematuria, recent trauma, suprapubic pain or costovertebral angle pain, or tenderness are helpful to identify a urinary source of fever, but are present in only a minority of episodes of presumed symptomatic infection. If localizing genitourinary findings are not present, fever in bacterial patients should be attributed to urinary infection only when there are no other potential sources. When the same organism is isolated from both the urine and the simultaneous blood culture, a diagnosis of CORT is presumed in the absence of any alternate source for the bacteremia. Microbiological techniques include microbiological diagnosis, urine specimen for culture collected directly from the catheter or tubing to maintain a closed drainage system. The organisms isolated by quantitative culture of the urine. 40 patients were identified based on standard microbiological techniques. As per standard operating procedures, the samples were processed routine aerobic bacterial culture and sensitivity by means of standard loop technique, where 2 microliter urine sample was inoculated on blood agar plate and McConkey agar plate. After 24 to 48 hours of aerobic incubation at 37 degrees centigrade, culture plates were looked for growth, where more than 10 power 5 colony forming units per ml is considered as significant. The colonies obtained were identified by standard methods. Organisms which were isolated from the urine specimens were subjected to standard identification and sensitivity testing by KB-Boyer disk diffusion method. My results are: a total 137 were positive for bacterial growth on culture. The overall incidence of CORT was 45.67%, predominated by female population. Total 93, that is 63.69% females, and 53, that is 36.3% male had CORT, predominated by female gender. The mean age of patients with CORT was in females 59 years and in males 61 years. Of total 137 bacterial isolates in patients with CORT, 57, that is 39.47% were E. coli, and 24, that is 17.52% were Klebsiella pneumoniae, 14, 10.21% were Pseudomonas aeruginosa, and 12, that is 8.76% were Enterococcus species, and 9, 6.56% were Acinetobacter baumannii complex, and 19, that is 13.86% was Coagulase positive Staphylococcus, and 5 were methicillin resistant Staphylococcus aureus. Total 101, that is 73.72% were gram negative bacilli, and 36, that is 26.28% were gram positive foci. The majority of GPCs were sensitive to linezolid, nitrofurantoin, and cotrimoxazole. All MRSA were sensitive to vancomycin. Escherichia coli and Acinetobacter baumannii complex were sensitive to tigecycline, colistin, meropenem, and amikacin. Majority of Pseudomonas aeruginosa were sensitive to colistin, tigecycline, meropenem, imipenem, piptaz, amikacin, ceftazidime, and ceftriaxone sulbactam. Klebsiella pneumoniae were best sensitive to colistin, tigecycline, meropenem, imipenem, ceftazidime, and piptaz. These are the bacterial isolates on some culture media. And this is the bar diagram for sex distribution, where females is 63.69% and males are 36.3%, where P is less than 0.001. The mean age of patients with CORT in females it was 59 plus or minus 2.3, and in males it was 61 plus or minus 0.8. And this is the pie diagram of organisms isolated, where E. coli constituted the major portion, that is 39.47%. Next is Klebsiella pneumoniae, and the next is Pseudomonas aeruginosa. Next is Enterococcus species, Acinetobacter complex, Coagulase positive Staphylococcus, and methicillin resistant Staphylococcus aureus. My conclusion is the gram negative organisms, Escherichia coli, Klebsiella pneumoniae, and Pseudomonas aeruginosa were the most commonly isolated than GPCs, with high mortality rates, female gender, increasing age, and longer duration of catheter in situ were risk factors for COT in present study. These are my references. Thank you.